Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Paul Pender. He's an ophthalmologist and he's the author of the book, Standing Up and Speaking Out for Patients and Doctors. Today's KevinMD article is titled Youth versus Experience, Who Wins in Medicine? Paul, welcome back to the show.
Hey, thanks so much, Kevin. It's great to be here again.
All right. So I think it's been a few months since we last spoke. How have you been doing?
Thanks. It's been a hot summer, as you know, in New Hampshire, and it's been good to get away on occasion.
All right. So for those who are interested in reading more or listening to you more, go to kevinmd.com/podcast. In the upper right-hand corner, there is a search button. You can search for Paul's previous podcast to hear his story and prior episodes. So today we're going to talk about the youth versus experience conundrum. Your KevinMD article talks about that. How did it come together?
Well, it started with reading an article that was posted in the Wall Street Journal from Harvard researchers who looked at 700,000 Medicare patients' results that dealt with both inpatients who were served by internal medicine specialists, hospitalists, and also surgeons. And they were categorized by age. And the conclusion of the authors of the article and their research was that the outcomes favored the younger internists that were associated with hospitalists, while the older surgeons had better outcomes compared to their younger peers. So I found it somewhat curious. So I wrote an article trying to break it down.
All right. So as you reflected on that article, what did you find out were some of the causes behind those results?
Well, I would say there were theories, maybe not so much causes. One theory from the authors was that perhaps the internists were more likely to keep up with newer drug developments and some treatments, while the older surgeons had perfected muscle memory and learned how to look for problems before they occurred. So, it was a breakdown that was kind of skewed by the fact that these were all inpatients and that they were all cases that did not include elective admissions. And we all know that it's also important to get patients in the best shape possible before their surgery. And so, it would have been good to have some other evidence that these were patients who had been through a complex preoperative evaluation. So anyway, I concluded by saying I think that perhaps the performance is dependent on the frequency of doing the procedure, but there may come a point of diminishing returns. And I claim that there's kind of an inverted U-shaped curve where, as a function of outcome, the type of frequency that you have may reach a point beyond which it doesn't really help. So in other words, you get to the point where you may be doing so many cases too fast that you wind up cutting corners and thereby reducing quality.
Now, you've been an ophthalmologist for decades now. As you reflect back on your career, can you contrast your technical skills as a surgeon and your patient care from when you first started out through the decades, and how has those skills evolved?
Okay, so I think when we are all residents, we are learning every day, and from both peers and from attendings who really are kind of the shining lights. And we try to adopt some of those same characteristics. And I felt I went to a great training program at Wills Eye Hospital, and I was ready to hang my shingle and do great work. And yet, when you're new, you are assuming a certain level of competence and being able to take on more complicated cases. And you learn from experience. And bad outcomes can sometimes give real good experience. But I think we wind up saying over time that between discussing results with our peers and reading articles and actually attending meetings with practical labs, we develop additional skills. And I think in the article that I quoted, there were observations made that the peak performance of surgeons was somewhere in the age group between 40 and 60, and the peak performance of the internists who were hospitalists was somewhat under 50. So I think that that surgeons, and I would say in ophthalmology in particular, you realize that every step of the procedure, let's say cataract surgery, is very critical. And if something happens with the early steps, it can actually complicate things down the road. So you wind up developing, I would say, a skill set that you're moving along, but you're looking for signs of trouble. And some of those signs of trouble can be very subtle, and they don't come right away. They take some experience. So finally, I would say that in looking at how this whole process of learning continues for physicians, it's something that I think every physician will acknowledge, but not always the public understands. And so, what I concluded in my essay that you were kind enough to publish is that, it probably doesn't matter the age of who's taking care of you, but it does matter how often they encounter problems that are similar to yours.
How many years from residency did you really feel that you were at the peak of your surgical power?
I think it took a few years to really gain that confidence. I built my own surgery center approximately 4 years after I started practice, and felt at that point in time that I could actually hire the people I wanted and be able to form a team. It's kind of like having a dance partner. I'm sorry. When you have a really good assistant in surgery, that person knows your moves and hands you instruments almost before you have to ask. So I really felt like I was providing patients with a better atmosphere for their surgery, more personalized service. And I felt as a control freak, I could actually hire the people I wanted and to schedule the surgery the way I wanted.
Now, I don't know how familiar you keep up with current surgical training trends. Some of the doctor groups that I frequent, they talk about how the limitation in work hours sometimes affects surgical training, meaning that they do fewer cases when they're in residency, and sometimes that affects their technical skill when they come out. So I just wanted to see what you thought about that. Has the work hour limitations, has that affected surgical training?
I think, unfortunately, the work limitations that were established by law have not always been observed. And students and interns and residents have all been putting in incredibly long hours, as they have traditionally. So I don't know if this limitation that was imposed is actually being observed. And I also think that in residency, we are under supervision, clearly. And so when you're out in private practice and you don't have someone scrubbing in on the case with you or understanding what maneuvers you have to go through, you have to gain some of that on your own. So I think all residents who finish from approved programs are going to have that basic core of skills that they need to practice. But then it also is incumbent upon them to see what new techniques develop. I mean, in ophthalmology, a lot of new things have come about, including all the new biologics that, while I was finishing my years in clinical practice, were just coming into clinical practice. And the whole idea about treating something like macular degeneration that was of the wet form, that you could inject something into the eye that would stop growth of new blood vessels. So that all came about during the time that I was in clinical practice. And now multiple agents are out there to provide these patients with a medical, if you will, or a drug delivery system that helps to preserve their vision. So So I think all physicians have to keep learning. And whether it's how to care for patients in the hospital, as that article talked about, or whether it's your surgical skill set, I think you still have to be willing to continue to learn about the new stuff.
Now, you work with new ophthalmologists over the decades. Have you noticed any difference in the training that they receive just coming out of their residency or fellowship?
Yeah, and it's interesting that you raised that. In one of the alumni magazines that I got from Wills showed a laboratory that helps residents develop surgical skills, microsurgical skills. And this is now a formal part of their training. Before, we would have eyes that had been donated to the Lions Club or others that were not suitable for corneal transplant that we would practice on. We had animal labs. We had other ways of gaining some expertise technically.
Mhm.
But I think that now there are really formal labs with multiple microscopes to be able to study a resident's technique of suturing or what have you. So yeah, now it's more formalized, and I think it's probably a good thing.
Now, if I'm a patient and I'm listening to you and I read this study, when choosing an ophthalmologist for cataract surgery, for instance, should age be part of that decision making process from the patient standpoint?
And as long as they don't have a tremor, I think they're they're okay. But clearly, I think that age is only one factor, and really the most important element I think for a good outcome
Hmm.
is people who do the same kind of work all the time. And if you are really a skilled surgeon and every week you're doing a fair amount of cases, you're gonna feel like, yes, I can bring to this patient my best efforts to get the best outcomes. Also, I think that having seen some complications earlier, you learn how to avoid those as you grow in your field. So I think frequency of procedures, or from the intern's point of view, of having to see someone with difficult kidney disease or whatever in the hospital, you develop certain algorithms that seem to work, and this is independent of age, I think.
Now, sometimes you hear these stories on the news about doctors practicing into their 90s, practicing into their hundreds in some cases. Now, what are some signs that physicians should look for to realize maybe they should slow down a little bit? Maybe they should hang them up, and maybe that I wasn't as good as I once was, and I may be, in fact, endangering patients. Now, what kind of questions should they be asking themselves to make sure that they're not practicing beyond their current capability?
How about starting with, do you remember where you parked your car today? you know, I think there are going to be cognitive and physical limitations that come with aging. There's no doubt about that. I think one of the other comments that I made at the end of the essay that you were kind enough to publish is that it also helps to gain some perspective from the nursing staff that works with these doctors. And you can't hide incompetence. You know that there are people who are going to be fair and honest about whether this doctor seems to still have the goods. And I think that certainly maybe around someone in their late 60s, early 70s, kind of like what you see in the airline industry where pilots are actually restricted after 65 from flying, at least on commercial airlines. I mean, maybe they can get private gigs. But I do think that there is kind of a spread where physicians or their partners would probably take them aside and say, you know what, I think it'd be better if you just did office-based work and not do surgery anymore. And I think that does occur fairly commonly.
We're talking to Paul Pender. He's an ophthalmologist and regular guest on the podcast by KevinMD, author of the book Standing Up and Speaking Out for Patients and Doctors. Today, we've been talking about youth versus experience, who wins in medicine. Paul, as always, tell us some of your take home messages that you want to leave with the KevinMD audience.
Well, first of all, Kevin, this has been a pleasure for me talking with you. I'm this has been going on for the last several years, and I really appreciate the opportunity to talk with you. I always find it a stimulating conversation. And so my take-home message is that, if you're doing your research, the doctor rating companies, I mean, really, this is survey stuff, and anyone can complete a survey, and they may be upset by what they got from the receptionist and not from the doctor. So I think that the rating services are kind of overrated. And I think that if you do your homework and talk to physicians, your primary care physician, and you talk to people who've had work done by the doctor that you're hoping to engage, then I think you've done the best you can. I think the question to ask that doctor is, you're recommending this treatment. How comfortable are you with this treatment, and how often do you do this kind of work? That's going to go a long way to satisfy the patient's concerns.
Paul, as always, thank you so much for coming on the show, sharing your time and insight.
Kevin, thanks again for having me.